Welcome, everyone, to the weekly Neurology Deep Dive. Today, our mission is really quite focused. We want to give you a comprehensive, educational look at Friedreich's ataxia. We've synthesized findings from 6 key sources covering everything from the basic science, the pathophysiology, right up to the latest in clinical management.
Exactly. Friedreich's ataxia is, well, it's a devastating condition, affects multiple systems, and it really demands our close attention, especially now, with the first disease-modifying therapies actually becoming available. So our aim here is to cut through all that dense literature and really distill the most practical, actionable insights from these recent papers and analyses.
Right. And before we dive in, just a really important note for everyone listening. This deep dive is strictly for educational purposes. There's absolutely no commercial goal here, and it is just a summary. We strongly, strongly recommend you go and read the full papers yourselves, get the complete data, the context, and, the full picture.
Absolutely crucial. With that said, let's get straight to the point for busy clinicians. Here's the practical summary, the key takeaways you need right now.
Okay, starting with management, Omaveloxolone. It's the first approved drug for adults and adolescents, age 16 plus. And the key finding: sensitivity analyses looking at the better quality, lower risk of bias studies confirm it gives a statistically significant improvement in neurological function. And that's measured specifically using the modified Friedreich Ataxia Rating Scale scores.
Then therapeutic monitoring. If you want an objective measure to track if treatments are working, left ventricular mass index, or LVMI, is really emerging as the most responsive cardiac marker. A pooled analysis showed a statistically significant improvement in LVMI after about 28.5 months of treatment with drugs that boost mitochondrial function. So LVMI, combined with the clinical scores like the modified Friedreich Ataxia Rating Scale, really needs to be part of the standard biomarker toolbox for all future trials.
And finally, safety. This is critical. Monitoring alanine aminotransferase and aspartate aminotransferase, the liver enzymes, is absolutely essential, especially when you're starting Omaveloxolone. These elevations tend to happen early, often within the first, say, 12 weeks. But the good news, generally, is that they're usually transient, they're reversible, and importantly, the big trials didn't show signs of severe liver injury, meeting those strict Hy's Law criteria.
Right, so that gives you the immediate clinical action points.
Yeah.
But to really grasp why these things work and why the disease presents the way it does, we need to start at the beginning, the molecular level.
Okay, so Friedreich's ataxia. It's the most common inherited ataxia we actually see in practice. Epidemiology-wise, it affects roughly 1 in 50,000 people of European descent. Globally, maybe around half a case per 100,000, but importantly, it's much higher in Caucasian populations and also in some Indian populations, which points straight to its genetic roots.
And those roots are in an autosomal recessive inheritance pattern. It's all down to mutations in the frataxin gene, the FXN gene, on chromosome 9. And in the vast majority of cases, we're talking over 95%, it's a very specific type of mutation. It's a massive expansion of a GAA triplet repeat located right in the first intron of that FXN gene.
And when you say massive expansion, what kind of numbers are we talking about?
We're talking a range from around 66 repeats all the way up to potentially 1,700 repeats. And there seems to be a critical threshold. The sources highlight that if you have fewer than, say, 100 repeats, it rarely causes the full clinical disease. You really need that substantial expansion to properly disrupt the gene's function.
So the expansion doesn't just break the gene, it does something else.
Exactly. It triggers something called heterochromatin-mediated silencing. Basically, the cell's machinery clamps down on that part of the DNA containing the FXN gene. It prevents the gene from being read, from being transcribed properly. And the end result is a dramatic, profound reduction in the amount of frataxin protein the cell can make.
And frataxin, of course, is vital. It's a highly conserved protein, mainly found in the mitochondria. Why is losing it so catastrophic for the cell's energy production?
Well, frataxin is right at the heart of cellular metabolism. It plays a key role in managing iron safely, that's iron homeostasis. And crucially, it's essential for making iron-sulfur clusters. These clusters are like tiny molecular helpers, cofactors, needed for tons of metabolic enzymes, including, critically, components of the electron transport chain, which is the cell's main power generator.
Okay. So less frataxin means that the whole system starts to break down. You can't make those iron-sulfur clusters properly, so the cell struggles to produce energy efficiently. You get reduced mitochondrial adenosine triphosphate.
Precisely. That's the core of the mitochondrial crisis in Friedreich's ataxia. And it's a double whammy. Not only is energy production hit, but the failure to manage iron means iron starts to build up, dangerously, inside the mitochondria. And free, unbound iron is highly reactive. It directly fuels a massive increase in oxidative stress, generating harmful reactive oxygen species that damage everything: proteins, lipids, even DNA.
And this oxidative stress, this damage, is what ultimately kills the cells, right? Targeting the tissues that need the most energy.
Yes, exactly. Tissues that are heavily reliant on oxidative phosphorylation, think the central nervous system, especially the dorsal root ganglia, the spinal cord tracts, and also the heart muscle, the myocardium. These are hit hardest, and that leads directly to the clinical symptoms we observe in patients.
So let's connect that molecular problem to clinical prediction. The genotype-phenotype correlation is important, but sounds like it's not the whole story. What's the main genetic factor we look at?
The length of that GAA repeat, but specifically on the shorter of the two alleles, we call that GAA1. That's the most significant predictor we currently have. And the relationship is inverse. So the longer that shorter GAA1 repeat is, generally the earlier the age of onset and the more severe the disease tends to be.
Okay, that sounds pretty predictive, but the sources mention it only explains part of the variability.
That's the crucial caveat. The length of GAA1 only accounts for, well, somewhere between 36% and maybe 50% of the variation that we see in age of onset, which tells us two really important things. First, you can't just use that repeat length alone to perfectly predict someone's disease course. And second, it strongly suggests there must be other factors at play, maybe other genetic modifiers or epigenetic changes that influence why some people have milder disease or later onset than others, even with similar repeat lengths. That's a big area for future research.
Okay, so if frataxin deficiency is the engine failure, where do we see the fallout? The clinical picture of Friedreich's ataxia is notoriously progressive and affects multiple systems.
Yes, the typical onset is usually in childhood or adolescence, often between 8 and 15 years old, almost always before age 25. It might start quite subtly, but the progression is unfortunately pretty relentless.
The defining neurological feature is that progressive ataxia affecting both the trunk, the axis, and the limbs. When we see that characteristic gait and coordination difficulty, where exactly is the damage? Is it all cerebellar, or is there more to it?
It's definitely not purely cerebellar. You could argue the sensory component is actually the dominant feature, especially early on. The ataxia arises from damage in several key places: degeneration of the dorsal columns in the spinal cord that carry proprioception, your sense of body position; severe neuron loss in the dorsal root ganglia; damage to the spinocerebellar tracts; and yes, some involvement of the dentate nuclei in the cerebellum itself. It's this combination of sensory loss and cerebellar pathway damage that gives you that characteristic, often quite severe, sensory ataxia.
And what are the first things that usually bring patients in, the initial complaints?
Gait instability, that's the big one. Reported in something like 77% of patients as the first symptom. Other early signs often include things like scoliosis, curvature of the spine, seen at about 23%, and frequent falls, around 20% reporting that early on.
You mentioned the sensory neuropathy. That seems almost universal.
It is. Progressive loss of proprioception, vibration sense, mainly in the lower limbs. It massively contributes to the gait problems and often causes significant neuropathic pain too, and you can confirm it quite clearly with basic testing.
How so?
Electrophysiology, nerve conduction studies. The sensory nerve action potentials, the SNAPs, are often completely unobtainable or at best have very, very low amplitudes. This reflects that severe loss of the large myelinated sensory nerve fibers coming from those damaged dorsal root ganglia. It's a really key diagnostic feature.
It's easy to fixate on the ataxia, but there are other serious neurological issues. Dysphagia, difficulty swallowing sounds like a major problem.
It's a huge problem, extremely common, reported in maybe 69 up to 98% of people, especially as the disease progresses. And it's not just quality of life. The real danger is aspiration pneumonia. That accounts for roughly 28% of non-cardiac deaths in Friedreich's ataxia. So assessing swallowing early and involving speech therapy consistently is absolutely vital.
And other murder symptoms. Spasticity comes up too, but maybe more in certain groups.
That's right. Spasticity often develops later in the disease, making mobility and comfort even harder. But it's notably more common in the late onset form of Friedreich's ataxia. The prevalence is estimated around 33 to 40% in late-onset cases, compared to maybe 12 to 15% in typical earlier onset cases. Something to keep in mind for the differential diagnosis in adults.
Okay. On a slightly more positive note, what about cognition?
Generally speaking, global cognitive function tends to be preserved. That's important for patients and families. Now, some studies have reported subtle issues, maybe with executive function or attention, but interpreting those can be tricky. It might be confounded by timing problems on tests due to the physical difficulties like the severe dysarthria, the speech difficulty that many patients develop.
Right. Now, let's shift to what the sources call the single biggest determinant of survival, the heart.
Yes, the cardiac involvement is absolutely critical. Heart disease develops in a huge proportion, somewhere between 40 and 85% of patients. And the myocardial damage is, without question, the major factor driving mortality. That figure you mentioned earlier, 62% of deaths are linked to the heart problem. It has to be front and center in our management.
What does the cardiomyopathy typically look like?
The classic pattern is concentric hypertrophy. That means the walls of the ventricles, particularly the left ventricle, become abnormally thick. Early on, the left ventricular ejection fraction, the pumping strength, is often normal, which can be falsely reassuring. But as the mitochondrial damage builds up in the heart muscle over time, that ejection fraction eventually declines, leading to heart failure.
So, what tools do we use to track this, often working with cardiology colleagues?
Well, an initial electrocardiogram often shows changes, like T-wave inversion, but they're not very specific. Echocardiography is key for detecting that wall thickening and monitoring overall function. But for the most detailed picture, and for prognosis, cardiac magnetic resonance imaging is really the gold standard. It lets us see that concentric left ventricular remodeling very clearly, and crucially, it can detect areas of focal myocardial fibrosis scarring, often seen as late gadolinium enhancement. That fibrosis signifies irreversible damage from the chronic oxidative stress.
Okay. Beyond the brain and heart, there are other significant issues, metabolic and musculoskeletal problems. Diabetes is mentioned.
Yes, frank diabetes develops in maybe 7 to 9% of patients. But that underestimates the problem, because around 30% actually have impaired glucose tolerance. The thinking is that frataxin deficiency directly affects the pancreatic beta cells, another high-energy demand tissue, impairing their ability to produce or respond to insulin effectively. It's another consequence of the core mitochondrial defect.
And body composition changes too.
It's interesting. Often, children with Friedreich's ataxia are noted to be short and underweight. But then as adults, they frequently tend towards being overweight. This suggests there might be systemic metabolic changes, possibly involving frataxin deficiency in fat tissue, affecting how the body stores energy.
And finally, the musculoskeletal system takes a hit as well.
Definitely needs proactive management. Scoliosis is very common, affecting anywhere from 63 to 90% of patients. And sometimes it can even be the presenting sign, appearing before the neurological symptoms become obvious. Also, that characteristic high-arched foot deformity, P. casvus, is seen in about 59% of patients, which can add to mobility difficulties.
Given how slowly Friedreich's ataxia progresses and how many systems are involved, actually measuring if a treatment is working, especially in a relatively short clinical trial, must be really tough. What clinical scales are proving most useful?
We rely heavily on standardized rating scales. The main ones are the Modified Friedreich Ataxia Rating Scale, or MFARS, and the Scale for the Assessment and Rating of Ataxia, SARA. The sources suggest that the Modified Friedreich Ataxia Rating Scale might offer a bit more granularity, potentially making it more sensitive to picking up smaller changes, particularly early in the disease.
And what does the natural history, the untreated progression, look like on these scales?
Well, data from the big European Natural History Study, EFACS, showed that activities of daily living scores worsened by about 0.93 points per year on average. This shows the scale is sensitive enough to detect change over time, especially in those with earlier onset, which supports its use as a primary outcome measure in trials.
What about tracking dexterity, especially for patients who might be using wheelchairs later on?
Simple performance tests like the 9-hole peg test are still very valuable. They give you an objective, timed measure of hand and finger dexterity, upper limb coordination. That's really important for assessing how treatments impact practical functional skills needed for daily life.
Okay, but we really need objective biomarkers, ideally from blood or another easily accessible sample, to track subtle changes. Measuring frataxin protein itself seems like the obvious place to start.
It does. And people are investigating frataxin levels in peripheral blood mononuclear cells, white blood cells, and also in skeletal muscle biopsies. We do know that frataxin levels generally correlate inversely with the GAA repeat length, which makes biological sense. But the challenge is whether measuring it in easily accessible cells truly reflects what's happening in the most affected tissues, like the brain and heart, especially when testing therapies designed to boost levels.
Right. What about neurofilament light chain? It's become a popular biomarker for general neurodegeneration. Does it work well here?
Unfortunately, the evidence for neurofilament light chain in Friedreich's ataxia is still pretty inconclusive. Most of the studies reviewed didn't find a clear association with the patient's age or with disease progression measured over a typical 2-year period. It might be that the specific type of damage in Friedreich's ataxia, mainly in the spinal cord tracts and dorsal root ganglia, just doesn't release enough neurofilament light chain into the blood or CSF to make it a reliable marker for tracking progression or treatment response in most patients.
Okay, so that brings us to something I found really fascinating in these papers, the idea of using skeletal muscle as a molecular readout. Clinically, muscle weakness might not be the biggest problem compared to the heart, but molecularly.
Wow, the picture seems quite dramatic.
It really is. Transcriptomic studies looking at gene expression in muscle biopsies from the gastrocnemius found a huge number of differences compared to healthy controls. Something like 1873 genes were differentially expressed. That's a massive molecular signature of disease, far more extensive than what you typically see in blood cells. It strongly suggests that even if it's not causing the primary symptoms, skeletal muscle is significantly impacted by frataxin deficiency at the molecular level.
That's a striking number of genes. What kinds of biological pathways are most affected? Unsurprisingly, the changes are heavily dominated by pathways involved in mitochondrial structure and function. That fits perfectly with the known role of frataxin. But here's a really critical finding. About 75% of the proteins that were downregulated in the muscle tissue are known targets of a specific transcription factor called nuclear factor erythroid 2-related factor 2, or NRF2.
NRF2, that's the pathway targeted by Omaveloxolone, the approved drug.
Exactly. So the muscle biopsy data provides this direct molecular link showing that the pathways affected by the disease are precisely the ones the drug is designed to modulate. It's a kind of molecular validation. And functional imaging backs this up too. Using phosphorus-31 magnetic resonance spectroscopy on calf muscle after exercise, researchers found clear deficits. The muscle has reduced capacity to synthesize adenosine triphosphate, and it takes longer to recover phosphocreatine levels after exertion. Basically, the muscle can't make energy quickly or recover efficiently, showing a functional consequence of that molecular damage.
So even though getting a muscle biopsy is invasive, the conclusion for trial design seems pretty clear.
It seems unavoidable, at least for certain types of trials. Skeletal muscle offers this accessible tissue where you can potentially take serial samples and directly measure if a drug is hitting its molecular target and having downstream effects. It really supports using muscle biopsies, especially in early phase trials, as a surrogate endpoint to get quicker confirmation of biological activity before waiting years for clinical changes.
Okay, let's shift gears now to the treatment landscape itself. The approaches being used or developed for Friedreich's ataxia seem to fall into 3 broad categories.
That's a good way to think about it. First, you have symptomatic management. This is about dealing with the consequences of the disease, managing the heart symptoms, controlling spasticity, providing essential physical therapy, speech therapy, and so on. This helps quality of life immensely, but it doesn't tackle the underlying cause.
Right. The second category includes drugs designed to augment mitochondrial function. The idea here is to help the mitochondria cope better, protect the cell from that oxidative stress caused by the lack of frataxin. This group includes Omaveloxolone, also drugs like idebenone, coenzyme Q10.
Exactly. And the third group, which is maybe the most exciting conceptually, includes strategies aimed at actually increasing the amount of frataxin protein. This could be through drugs thought to boost the FXN gene's expression, like erythropoietin or nicotinamide, or, looking further ahead, the various gene therapy approaches that are in development.
Let's focus on Omaveloxolone first, since it's the approved agent. It works by activating that NRF2 pathway we just discussed. Can you walk us through what activating NRF2 is supposed to achieve in the cell?
Sure. By activating NRF2, Omaveloxolone essentially triggers the cell's own defense mechanisms. The goal is to suppress the chronic oxidative stress and inflammation that are hallmarks of the disease. At the same time, it aims to improve mitochondrial function and even promote the creation of new mitochondria, mitochondrial biogenesis. It's basically trying to bolster the cell's resilience to cope with the ongoing frataxin shortage.
Okay. There was a large meta-analysis that pulled data from studies using drugs from that second category, the mitochondrial boosters, looking at their overall effect on neurological function. What did that analysis find?
It found a pretty solid signal. When they did a sensitivity analysis focusing only on the studies with a low risk of bias, and this was mostly driven by the Omaveloxolone data, there was a statistically significant improvement in neurological scores. They used a combined measure of the Friedreich Ataxia Rating Scale and the modified Friedreich Ataxia Rating Scale, and found a standardized mean difference of -0.32. This suggests a real, albeit modest, slowing of neurological decline.
And beyond those initial trial results, is there any longer-term data suggesting sustained benefit?
Yes, there's a propensity-matched analysis that compared patients treated with Omaveloxolone to a large natural history cohort, the Friedreich Ataxia Clinical Outcome Measures Study Group. And that analysis suggested that over a 3-year period, Omaveloxolone slowed disease progression by about 55% compared to the untreated group. Seeing that kind of effect sustained over several years is really encouraging, suggesting true disease modification.
Now, shifting back to the heart, the main survival factor, how do these drugs impact cardiac measures, particularly that key marker left ventricular mass index?
The left ventricular mass index really stood out as being responsive to treatment. The pooled analysis showed a statistically significant improvement, a standardized mean difference of minus 0.34 after a median treatment duration of about 28.5 months with mitochondrial augmenting drugs. Interestingly, this effect was mainly driven by longer-term data from studies of adenosine and also deferriprone, suggesting that reversing or slowing cardiac changes might take longer than seeing neurological benefits.
And what happens to the heart in untreated patients over similar time frames?
Well, in stark contrast, the analysis showed that left ventricular mass index essentially remained stable in untreated patients over a typical 12-month period. The standardized mean difference was very close to zero, below 0.01. This comparison really strengthens the case that the improvements seen with treatment are a specific drug effect, not just background noise or natural variation, and it validates LVMI as a useful treatment biomarker.
Did any other, maybe simpler cardiac measures show a benefit, like ejection fraction?
No, unfortunately not. Other common measures like left ventricular ejection fraction or fractional shortening didn't show any statistically significant change after treatment with any category of drug. This likely reflects the fact that ejection fraction often stays normal until quite late in the disease. So these measures just aren't sensitive enough to pick up earlier treatment effects on the heart muscle itself.
Okay, and what about that third category treatments aiming to directly increase frataxin levels? Any success shown there yet in the pooled analyses?
For the drugs looked at so far that aim to increase frataxin, the analysis didn't show a statistically significant difference in frataxin levels measured in peripheral blood cells. Nor did they show a significant improvement in neurological scores using the scale for the assessment and rating of ataxia. It highlights the ongoing challenge, really, of effectively increasing frataxin protein in the key tissues that need it most.
So, pulling all this biomarker and outcome data together, what are the key takeaways for designing better clinical trials in the future? The duration seems critical.
Absolutely critical, because many of these measures, both clinical scales and imaging markers like LVMI, change quite slowly or didn't change significantly over shorter periods like 12 months in these analyses. It strongly implies that future randomized controlled trials really need to be designed for longer durations, probably at least 24 months, maybe even longer, to have a good chance of detecting meaningful, durable clinical benefits in this slow-progressing disease.
And we shouldn't rely on just one measure. The idea of a biomarker toolbox comes up.
Precisely. Relying on a single outcome measure is probably not enough. The recommendation is to use a combination, a toolbox. This should include robust clinical scales like the modified Friedreich Ataxia Rating Scale, which showed sensitivity to Omaveloxolone, alongside objective imaging markers like left ventricular mass index, which captured the cardiac effects seen with other mitochondrial drugs. Using both allows you to assess impact on the different core aspects, neurological and cardiac, of this multisystem disorder.
Okay, let's bring this into the clinic. Moving from trials to everyday practice, we really need to understand the real-world management of omaveloxolone, especially regarding those liver enzyme elevations, the aminotransferases that we're seeing.
Right. The trial data showed alanine aminotransferase went up in about 37% of patients, and aspartate aminotransferase in about 22%. Now, those percentages might sound a bit high, but the context is really important. The general consensus, based on the trial experience, is that these elevations are usually asymptomatic. Patients don't feel anything. They tend to be transient, meaning they come back down. And importantly, they were reversible if the drug was paused or the dose reduced.
What's the thinking behind why these enzymes go up? Is it actual liver damage?
The prevailing theory, which is supported by preclinical work, is that it's likely not direct liver toxicity in the usual sense. Instead, it might reflect a kind of physiological adaptation by the liver, or perhaps more likely, it could be an indicator of target engagement, a sign that the drug is activating that NRF2 pathway as intended. We know NRF2 activation can influence various metabolic pathways, including ones involving these aminotransferase enzymes.
The sources make a point of mentioning Hy's Law criteria were not met in the trials. Can you explain why that's such a critical piece of safety information?
Sure. Hy's Law is basically the regulatory standard, the bright red line, for identifying potentially severe, serious drug-induced liver injury. To meet Hy's Law, you need a specific, dangerous combination. The alanine aminotransferase, or aspartate aminotransferase levels have to be quite high, greater than 3 times the upper limit of normal, and at the same time, the total bilirubin level has to be elevated, usually greater than 2 times the upper limit of normal. The fact that no patients in the pivotal Omaveloxolone trials met this strict criteria is very reassuring. It strongly supports the idea that the enzyme bumps seen are more of an adaptive transient effect, not a sign of impending severe liver failure.
Okay, so let's walk through the monitoring protocol that's actually required according to the drug's label when starting omaveloxolone.
Right. Before you even start the drug, you absolutely must get baseline levels of alanine aminotransferase, aspartate aminotransferase, and total bilirubin. That's your starting point.
And then, once treatment begins, how closely do we need to monitor?
It's quite intensive initially. Monitoring is required every month for the first 3 months. That's because the data clearly shows these elevations typically happen early, almost always within that first 12-week window. After those first 3 months, the guidance allows for monitoring periodically thereafter. But you still need to be vigilant. And importantly, the sources note these early spikes often resolve on their own, even without stopping the drug.
But what's the absolute threshold where you must stop the drug immediately?
Immediate discontinuation is required if the aminotransferases go above 5 times the upper limit of normal, or if they reach 3 times the upper limit of normal and there's any sign of liver dysfunction, which usually means the bilirubin level is also going up. That's the standard safety net to prevent true injury.
Now let's talk practicalities. In a busy outpatient clinic, monitoring isn't as frequent as in a trial. Expert opinion seems to suggest maybe being a bit more cautious.
That's exactly right. The expert consensus leans towards a slightly more conservative approach for neurologists managing patients remotely, outside of a tightly controlled trial setting. This generally means considering temporary discontinuation, pausing the drug if the aminotransferases rise to 3 times the upper limit of normal or higher, even if the bilirubin is still normal and there are no other signs of liver dysfunction.
And why the lower threshold for pausing in practice?
It's really about managing the practicalities and risks of less frequent monitoring. If you're only seeing the patient every few months, it's harder to catch a rapidly rising level before it hits that mandatory stop threshold of 5 times upper limit of normal. Pausing at 3 times gives you a safer buffer. You then repeat the tests, maybe after 2 weeks, to see if the levels are coming down, confirming it's transient before deciding to restart.
Okay, so if you do pause the drug because of elevated enzymes and then the levels stabilize or come back down, how should you go about restarting it, especially thinking about keeping the patient on this long-term therapy?
A careful, structured reinitiation plan is really key for patient confidence and adherence. The typical approach involves starting back at a lower dose and gradually titrating up. For instance, maybe you start at 50 milligrams, then go up to 100, then back to the full 150 milligram dose. And during this retitration phase, you'd monitor the liver enzymes much more frequently again, perhaps every 2 weeks for about 3 months, just to make sure everything stays stable. This stepwise approach seems to work well in practice for keeping patients on this important therapy long term.
So the key message seems to be balancing that need for long-term adherence with really diligent safety monitoring, especially in those first critical months. Understanding how to manage these common, usually transient enzyme elevations is crucial for patients to get the potential long-term benefits. #tag outro.
Exactly. So as we wrap up this deep dive, let's just quickly circle back to those core clinical and monitoring takeaways from synthesizing these 6 papers.
Right. First, omaveloxolone. It marks a real step forward, showing a statistically significant improvement in neurological function, and that's best captured by the modified Friedreich Ataxia Rating Scale in the right patient group.
Second, left ventricular mass index. It's emerged as a vital objective marker for tracking treatment response in the heart, especially over the longer term, needing to see those cardiac benefits, which we know are crucial for survival.
And third, that liver enzyme monitoring. Alanine aminotransferase and aspartate aminotransferase need careful watching, particularly in the first 3 months of omaveloxolone, demanding close follow-up because those transient elevations are common and appear early.
And we wanted to leave you with a final, maybe provocative thought. Building on those striking molecular findings in skeletal muscle, the discovery that the loss of frataxin leads to such dramatic, widespread changes in the muscle's gene expression impacting mitochondrial pathways and RF2 targets, it really suggests that skeletal muscle might be accumulating significant damage quietly, progressively throughout a patient's life, even if it's not the main source of disability early on.
Which implies that muscle biopsies, despite being invasive, could actually be a uniquely valuable window into the disease's true molecular course. It might offer a way to track the impact of therapies directly at the tissue level, moving beyond blood markers that might be less reflective of what's happening in the most affected systems.
It's a critical perspective,
Yeah.
especially as we move toward therapies like gene replacement, where demonstrating target engagement and molecular correction in peripheral tissues like muscle could become absolutely key.